Hello, everybody. Thank you for being here. I'm very happy to share a little bit of science and knowledge with you. I'm gonna talk about EPM2 AIP1 immunohistochemistry as a surrogate of promoter methylation analysis in endometrial cancer. My name is Maria Santacana, and I'm responsible of immunohistochemistry core facility in IRB Research Institute of Lleida, Spain. Endometrial cancer is the most common cancer of the female genital tract and the fourth commonest site after breast, lung, and colorectal cancer. It arises from the inner layer of the uterus called endometrium. Traditionally, it was classified as type 1 and type 2 endometrial cancers. Type 1 endometrial cancer is estrogen dependent, is also called endometrioid endometrial cancer, occurs more often, and has a better prognosis. On the contrary, type 2 endometrial cancer, also called non-endometrioid endometrial cancer, is not associated with estrogen exposure, is less frequent, fortunately, and has worse prognosis and higher mortality. A few years ago, TGCA classified endometrial cancer into 4 molecular subtypes. The first one is the polymutated subtype. Here we have endometrial cancers with mutations in the gene encoding polymerase epsilon. And these cancers have good prognosis. Then there is a second subtype with endometrial cancers with deficiency of mismatch repair and high microsatellite instability. This subtype has an intermediate prognosis. Then we have another subtype with cancers with mutations in the TP53 gene and abnormal expression of the P53 protein. This subtype has all cancers here have poor prognosis. And finally, we have the subtype with no specific molecular profile. The differentiation of endometrial cancer subtypes nowadays is based on immunohistochemistry and molecular techniques. Approximately 25% of endometrial carcinomas demonstrate microsatellite instability due to defective in mismatch repair of the DNA. We are focusing in our work in this subtype here. Why is it important to test for mismatch repair status in patients with endometrial cancer? It's important for 4 reasons. First of all, as a diagnostic tool, as mismatch repair deficiency is considered a marker for endometrioid type endometrial cancer. As a pre-screening tool to identify patients at higher risk of Lynch syndrome. As a prognostic tool, as I mentioned, within the molecular classification of endometrial cancer, and as a predictive tool, as it predicts response to immunotherapy. Mismatch repair protein expression in tumor tissue can be analyzed using immunohistochemistry. The four most common defective mismatch repair proteins are MLH1, MSH2, MSH6, and PMS2, and they can all be analyzed by immunohistochemistry. So here in this image, we can see an endometrial cancer with loss of expression of MLH1. We can also see the nuclei from the stroma, which stains positively, and the tumor with loss of expression, as I mentioned. In most guidelines, MLH1 methylation analysis is requested for all endometrial cancers that show loss of MLH1 expression. Is it important to distinguish between familiar tumors and sporadic tumors? Because familiar tumors usually have a germline mutation in a mismatch repair gene, and then they acquire a second somatic mutation in the same gene. In sporadic tumors, usually biallelic silencing by promoter hypermethylation of MLH1 occurs. So the vast majority of MLH1 PMS2 deficient tumors are sporadic and show MLH1 promoter methylation. There are many MLH1 methylation tests. The one we use in our lab is pyrosequencing. But what happens with this methodology? They are time-consuming methods, labor-intensive, and therefore costly to perform. Here, let me show you a schematic representation of the promoter region of MLH1. Regions A and C are the most frequently altered, so methylation tests must cover all potentially methylable islands. Few years ago, EPM2 AIP1 immunohistochemistry was suggested as a potential surrogate of promoter methylation in endometrial cancer. This work mentions that MLH1 acts as a bidirectional promoter with the EPM2 AIP1 gene. Methylation of MLH1 promoter region leads to the transcriptional silencing of both MLH1 and EPM2 AIP1. So, for all the advantages that this would entail, we decided to set the objective of confirming the role of EPM2 AIP1 as a surrogate of MLH1 promoter methylation. So we collected 70 endometrial cancers with MLH1 loss of expression, and we performed promoter methylation analysis by pyrosequencing. Then we collected 30 controls, endometrial cancers with MLH1 preserved expression. And we performed immunohistochemical analysis for EPM2 AIP1 of these 100 endometrial cancers. These cases and controls were from a cohort from Spain, Lleida. And what we obtained from those hypermethylated cases, we saw that all hypermethylated cases exhibited negative nuclear expression of EPM2 AIP1 as we expected. Here we can see an example of an hypermethylated case that exhibits EPM2 AIP1 loss of expression by immunohistochemistry. Here we can see the tumor, all these glands negatively stained, and all the stroma, these cells around the tumor with positive immune expression of the protein. So that's necessary to consider the technique valid. What happened with those cases that were not hypermethylated? Well, we had 5 cases that showed positive nuclear expression of EPM2 AIP1, which was what we expected. So here we can see an example as well of a not hypermethylated case. So as we expected, with a preserved expression of the protein, EPM2 AIP1 positivity here in endometrial cancer glands and also in stroma cells. But from those not hypermethylated cases, 3 cases showed negative nuclear expression of the surrogate. So these cases were called discrepant cases. In this table, we can see summary of all those not hypermethylated cases. And here, the 3 that didn't correlate at the beginning because they were not hypermethylated, as I mentioned, and the immunohistochemistry for the surrogate was negative. What we did here was to repeat MLH1 methylation status assessment in macro dissected surgical specimen. And then here, yes, all 3 cases became hypermethylated. Let's see a few examples. This is one of those cases, not hypermethylated at the beginning. In fact, it was near the cutoff point. And immunohistochemistry was negative, as I mentioned. What happened here was an endometrial carcinoma arising from atypical hyperplasia. So EPM2 AIP1 was negative in endometrial cancer areas, but positive in hyperplastic zones. So when we macro dissected and we enriched sample with these cancer lesions, yes, then we obtained a hypermethylated score. So also it was discrepant at the beginning, it was concordant at the end. Then another case, so the same happened here, not hypermethylated on the curettage biopsy, because the immunohistochemistry of EPM2 AIP1 was negative, but this was a curettage with low tumor percentage and extensive necrotic areas. So EPM2 AIP1 was negative, and methylation score was near the cutoff point. When we, in the surgical specimen, macro dissected the area with loss of expression of EPM2 AIP1, so the cancer area, yes, then the methylation score after this macro dissection was about 60%. So it was coincident with what we expected. Here we have the controls. All the controls showed EPM2 AIP1 positive nuclear expression, so concordance between both techniques was 100%. We wanted to expand our series with independent series from our colleagues in Austria. So we added 30 MLH1-negative endometrial cancer and 30 controls. And here the agreement between MLH1 hypermethylation and immunoreactivity of the surrogate was near 100%. For all this, we can conclude that the immunohistochemical analysis of EPM2 AIP1 is a good surrogate for MLH1 promoter methylation tests, that our results suggest higher specificity of the immunohistochemical test, as it allows to evaluate results using histological samples and to avoid false negatives due to normal tissue contamination or low tumor percentage, and that EPM2 AIP1 immunohistochemistry is a cost-effective technique. We published our work last year, 2025, and also ESGO-ESTRO-ESPE guidelines recommend the use of the surrogate in endometrial cancer, so we encourage pathologists to use it on their daily practice. And this is all. Thank you very much for your assistance.